Okay, welcome back. This is Anesthesia101online.com. I'm your host, Siv. So this is episode 4. We're going to talk about antihypertensives, things that you wanted to know but were afraid to ask. So let's jump right into it. I'm going to share my screen. And there, and there. Choose share screen. All right, here we go. Let's look at some notes. Forgive me for my notes. I like to highlight. I like colors, so it pops out at me more often than not. So let me move this a little bit here so you can see my screen. So we're looking at the beta blockers, alpha blockers. So we'll go through that, a little physiology, a little background before we start. So what we got is beta 1 receptors, inotropics. So this is your contraction phase. Chronotropy, rate and time. We're looking at dromotropy was conduction, velocity, and then postsynaptics, cyclic accolades, and we'll go through that ATP and AMP, monophosphates. So we're looking at phosphorylations. Beta 2s, we'll look most primarily at the lungs. So those are bronchodilators, vasodilators. We also utilize those in some medications as far as the mechanism of action. It's mostly smooth muscle and glandular tissues. And alpha 1s, we're looking at peripheries, arterial venous, vasoconstriction, postsynaptic. We're looking at afterload, left ventricular afterload primarily. So that's a little physiology. Oh, one more. We've got one more. This is where your alpha 2 postsynaptic receptors, mainly in the central brainstem. I wasn't too sure about this, so I think it's the locus coeruleus. So I'm saying that right. This is where all your, when we're talking about sedation, the alpha 2 agonists, your presidex and your clonidine is where this works. So that's a little synopsis of that, a little physiology. Just jumping right to it. So the drugs I'm going to go over is just the common drugs we use IV intravenously. So first we're going to look at is metoprolol, or also known as low pressor, which we use every day in our anesthesia care. So it's a beta 1 selective antagonist. And I got some notes too, of course. I'm looking down a little bit here. Sorry, guys. Okay. So it's a beta 1 alpha receptor competitive antagonist primarily. Prevents inotropic and chronotropic responses. The bronchodilators, the vasodilators, and metabolic effects of beta 2 receptors remain intact because this is a beta 1 receptor antagonist. Then we want to be a little leery when utilizing this medication, especially somebody with COPD or peripheral vascular disease. They can have untoward effects, so you want to rule out in hypoglycemia, because if you're given a beta blocker, it causes glucogenesis to be subpar, and so that's why we always want to give glucagon if somebody's been on beta blockers for an extended time, or that's the antidote for that. It's about 3 to 4 hours half-life. So I'm gonna look through some more, and since I'm sharing my screen, here I got most cardio selective here. Heart rate's less than 45. You want to hold off on that. Long acting. Here's a little tidbits. Long-acting essential hypertension we use for it. Just be careful with the asthmatics, because actually no, it's preferably reversed for asthmatics because it is only a beta 1. It's not a beta 2. All right, let's jump into the next one. The short but rapid short-acting medication we use. Anesthetic esmolol. So it's still a beta 1 antagonist. Let me write through my notes real quick here. So esmolol, so going back to the dosage, I skipped that part here. And low pressure, I usually give for IV, depending on your hospital protocol and your practice. You may give 1 milligram or 2 milligrams, depending on your clinical judgment. I usually give 1 milligram every 5 minutes until I get a therapeutic effect with the low pressure. So let's go back to esmolol. Esmolol, I usually give 10 milligrams, see how they react to the medication. It is quite rapid onset. The limitation half-life on esmolol, because it's giving 9 minutes. So if you don't know what your rate is, you can give the esmolol to distinguish what kind of rhythm you're running, or what kind of arrhythmia that the patient's having. So Esmol is great in that. And the beauty of Esmol, it is eliminated by the plasma esterase, as we would call from our readings and our literature review. So it's rapidly short acting. It's the beauty of it. Ultra lowers the heart rate to distinguish, like I said here, I got here, lowers the heart rate to a lesser extent to the blood pressure. And here's a little references I've used as far as making this video. It's half-life's about 9 minutes. Onset's about 1, 2. Yeah, you look at different books, you'll see 1, 2 to 5. That's why I put that there. And to run a drip, that's the courses that we use to run a drip. And these are the side effects you'll see with the Esmol. Okay, moving on. So the next popular drug we have is labetalol. Labetalol, let me scroll that down here a little bit since we're sharing my screen. So labetalol, it's alpha 1, beta 1, beta 2, non-selective. That's why it's non-selective, because it's hitting all the receptors here. And you'll see here, I got an exam because the pimped up question that people will ask you, or an anesthesiologist or CRNA will ask you, is more beta than alpha, with a ratio of 7 to 1 primarily. So let's look at the mechanism of action for that. So the way it works is it's the same kind of pathway, but it's going to hit the lungs. So as we looked at this, the same type of course action we saw at the low pressure here. Let's scroll back up. And so this plasma esterase is the Esmol we talked about. Continue on here. We'll look at the pharmacokinetics with that. With the labetalol, it can cause, because it's non-selective, it can cause bronchodilations, conduction blockades, and myocardial depression. So again, little leery with the congestive heart failure. Anybody that has some kind of pathophysiology with that matter. It's usually contraindicated if somebody has a atrioventricular block. You want to be a little worried of that. Somebody has a heart block, you want to avoid that. And like I said, it's usually conduction problems you want to avoid with these patients. And a little leery with the asthma and the COPD person, like I said, it can cause bronchospasm because it's a non-selective drug. So be a little worried. Let's look at notes when we're here. Usually the stuff I highlight in yellow is what's pertinent. Let me see. I think that's a lowest upside reflex without reflex tachycardia. That's what we saw there. I think that's it. Like I said, I don't do cardiothoracic much, or a little bit of vascular in my practice, but this is what I've learned, and this is what I've seen in notes as far as literature. It may be new stuff out there that's people do this every day, but this is a little quickie run through of what the drugs we use most of the time. Okay, let's move on. What else we got here? I mean, the most, sorry guys. Okay. And we'll scroll down. Nitroprusside. So I got this from Nago Help. So the way the mechanism action for that drug is what I have in my notes. Is it's it works. It interacts with the sodium. The actual medical term, or pharmacological term, is sodium nitroprusside. It interacts with the oxyhemoglobin, dissociating immediately to form methyl-globin, which releases cyanide and nitric oxide, but thereby causing vasodilation, specifically in the arterioles. Once released, the sodium oxide, nitric oxide activates the glycinate cyclase, which is mostly prominent in the vascular smooth muscles, increasing intracellular concentrations of cyclic GMP, which is glycinate monophosphates, which this in turn causes calciums to enter the cell and increase calcium uptake. Because the increased uptake in calcium, we cause smooth muscle endoplastic reticulum to produce vasodilation. So that's how these guys work as far as the pharmacological agent. Side effects, of course, you just heard, it does cause cyanide toxicity and methylglobin anemia. So you gotta be wary of that. and it'll cause high concentration of thiocyanate, representative of toxic side effects of sodium nitroprusside. It can increase cerebral blood flow, can cause worsening hypoxic pulmonary vasoconstriction, and decrease platelet aggregation. Some symptoms we can see with the cyanide toxicity. Usually these patients present with hypertension, obviously, with infusion. So usually responsive by you just shutting off the drip, basic thing. You could check the partial O2 in your blood gases and look at your different type of labs that you have out there. So you can, if the patient's awake, they're usually fatigued, they're bringing in the air, some nausea, some confusion. Those are the kinds of things, and you don't want it to get worse too. Seizure and coma is what the literature is writing here. So that's nitroprusside. All right, let's move on. Let's have them go through this real quick. I'm not going to stay long. The friend or cousin is nitroglycerin. The difference in the, as you see here in my notes, the nitroprusside, more arterial than venous. It blocks the alpha 2's blocker before discharge rebound hypertension. So if you're de-seeing this medication rapidly, you have that rebound hypertension with that. So nitroglycerin, more venous than arterial, and we actually can see here the mechanism as I described earlier. The nitric oxide activates the soluble guanine cyclase and diphosphorase, phosphorates it, and then changes GTP to cyclic GMP, which causes smooth muscle. And then here's more of the pharmacological mechanism action, how it works right here, as I described with the endoplastic reticulum. You can see there. That's how nitroglycerin works. What else? I think that is it. Oh, I'm sorry. I didn't go over the dosages. I'm sorry about that. Let's look at nitroprusside. And the usual dose for that is 0.25 mics per kg per minute. Like I said, I'm basing on my institutional protocol. It's up to you what do you use in your institutional protocol. And then with the nitroglycerin, we use anywhere 0.05 mics per kg per minute is where we're starting doses. But then again, other facilities are right for 10 milligrams per minute. So depends on what you get. This is just my take on it. Your facility may require other different things. So depends on where you work. A couple more things and then we'll wrap it up. Let's see here. I can pull that up on my screen. Let's see here. Let's go to, yes, let's pull this up right here. And we'll go to, yeah. Sorry, my screen's going fast for you guys. Yeah. I want to see. I want to pull up certain material. Hydralazine. So particularly we'll concentrate hydrolazine. Just be careful of hydrolazine. I mean, it has its place. I see residents use it quite often, and with not the understanding that this will eventually cause some kind of prolonged hypertension down the road. So be a little wary if you're using this. And the way this drug works is it's a vasodilator, of course. It's a phenothiazolidine derivative, activates the guanine cyclase to produce vasorelaxation, therefore decreases blood pressure. It affects more arterioles than veins, so just be aware of that. So I got here written in red, dilates arteriole, not veins. So this is what you really what happens is the calcium from the SR alters the calcium via the, I want to say, inotropic phosphate 3, and then increases cyclic GMP, and then nitric oxide combines with isoboride, especially sevoflurane hypertension, dilates arterioles and veins. Basically, it hyperpolarizes the activation of calcium, decreases systemic vascular resistance and afterload. And it looks like I got this from Stolting, yeah. Pharmacology and physiology, anatomy, physiology, I want to say. That's where I got that from. It has more. I got this from Goldman and Gilman. It basically hyperpolarizes agents via the calcium channels, altering intercellular calcium via IP3 receptors. So with the hydralazine, like I said, be a little wary. Don't just go ahead and just give it like water. The reason I like using it, and I'm selective with this drug specifically, is when somebody's on beta blockers, they got a slow heart rate. This is a great drug to utilize, because then you're not lowering your heart rate and you just want the blood pressure to be lower. That's the reason a lot of residents, a lot of people that are training utilize it or use it in their practice every day. And with that, usually the dose, I want to say it comes in anywhere from 1.25 milligrams. Just give a dose, and it onsets about 10 to 20 minutes. Depends on what literature you're looking at, but how long it lasts, about 3 to 6 hours. So just be careful you're using a licensed drug. So just be a little wary about that. The last I want to touch on is, like I said, this is just a quick rundown. There's multiple drugs, the Chitalis, so many out there that we use every day, but I'm just going to do a quick one today. So I'm looking for diltiazem. So we use this for rate control, and the way diltiazem works, it works on the L-type channel receptors, the alpha-1 subunit, blocks the calcium channels at the AV nodal. Treating SVTs, minimal effects on cardiac depression, likely interact with beta blockers or decrease cardiac contractions. And same thing, got that from Stolting, Pharmacology and Physiology. That's where I got that from. So with the calcium channel blockers, for namely diltiazem, you see a low contraction, which also, because of cardiac output, will have a low blood pressure, inotropic, chronotropic effects. Conduction velocity is less than dermatropy. I think we spoke about as far as conduction pathways. Then oxygen consumption is increased. You can see this with Nafid and nicardipine also with that. So that's it. A little quickie on all these drugs that we utilize every day. Hope you got something today. Again, this is Anesthesia101online.com. I'm your host, Siv. Leave me a comment. I want to say next week or so, coming very soon, I'll be starting to do a Zoom coaching call as far as helping people study for their boards. I mean, I've been there. I struggled through it, so I know how you feel with all the pressure of being done with clinicals and finally now having to sit down and pass the boards. I'll show you some ways that I've utilized. So email me at info@anesthesia101online.com. We'll get together. I'll give you the Zoom link and we can talk more offline. All right, stay tuned. I'll see you guys next time. And I'm gonna stop.